And I'd like to introduce Dr. Rana Saeed, who will be talking about seizures. So if you'd like to go up.
Right. Okay. Can everybody hear me okay? Thank you very much for the invitation to speak to you today. I know that seizures are an important element of PURA syndrome. And so today, my goal is really for us to kind of think about it, think about what we're missing, maybe some options for the future, and look at some parallels and other developmental epileptic encephalopathies that maybe we can learn from. I am a professor of pediatrics and neurology here at the University of Texas Southwestern Medical Center here in Dallas. And I've been there for 21 years, and so my practice is really pediatric epilepsy, difficult to control seizures, and genetic epilepsies. All right. Okay. We're hoping that this works. Okay, here we go. So this is just I can't start a talk about a condition that without saying anything about the background, although you have heard a lot of great science conversations today. But I think that the biggest thing that I'm going to be saying is that there's a lot we still don't know. PURA has been described only since October of 2014, which means that really everything that we talk about related to phenotype, related to severity of disease, the entire story and natural history is not yet fully elucidated as more and more people are identified with that condition. The common features, as you know, are low tone, delay, and seizures, poor feeding, sleep apnea, hypoventilation, intellectual disability are all common features. Seizures affect about 50 to 70% of people living with PURA syndrome. And so our focus today is going to be on seizures and the recognition all the way to treatment. It is important to know that some of the things that we'll be talking about really don't have a deep scientific basis. Many of our studies are based on case reports. And so just kind of that we're going on this journey of exploration. You know, and our scientists have already spoken earlier about the PURA gene and PURA alpha, which is really essential for postnatal brain development and synaptic function. And I'm going to say this little one statement here that we'll talk about later regarding this potential downregulation of GLUT1, which is a very important glucose transporter, which might be influencing metabolism. And I think we've got some scientists here who've been working on that. So what are the seizure characteristics in PURA? We know that seizure onset starts in infancy to early childhood, with the vast majority before age 5, and that seizures can be any type of semiology there, but focal seizures, generalized, myoclonic seizures, infantile spasms. And the epilepsy phenotype itself is variable from some people who have more well-controlled seizures and others where they can be much more difficult to control, including infantile spasms and Lennox-Gastaut syndrome. We know, and we've heard this, there was a lot of discussion in the panel that there's really no clear genotype, phenotype correlation regarding seizure types and severity. There are some features, though, that might be associated with a higher risk of poor seizure control, such as more profound global developmental delay, perhaps more profound hypotonia, or if the seizures are of earlier onset or get refractory sooner. There is some evidence that suggests that the microdeletions may have a more severe phenotype than single nucleotide variants. But again, a very robust conversation was already had before lunch about this. And the EEG does not, in some of our genetic epilepsy conditions, there may be characteristic or hallmark EEG patterns. That's not the case here. And so we can see multifocal spikes, we can see slowing of the background, seizures, or hypsarrhythmia. So what's the diagnostic approach? Really, it's clinical suspicion. We were just at lunch talking about clinical suspicion. And again, it sounds so like, yeah, you have to think about it. But remember, in a rare disorder where perhaps not every neonatologist is thinking of it when your child is in the NICU, or as children get older and become young adults, we have this whole cohort of people that what are the features of the disorder as they get older? And so clinical suspicion and genetic testing are going to be hallmarks. The EEG is essential for seizure characterization. We know that neuroimaging is typically normal or nonspecific, and that the mutation is confirmed often with next generation sequencing. I'm going to go to a little vignette just to kind of anchor us on a couple of principles. So this is a 9-month-old with global delay, low tone, and feeding difficulties. The baby had poor head control with minimal babbling. At 10 months, there were these events that were worrisome of eye deviation and limb stiffening that was lasting up to 30 seconds. After it was over, the child was back to being playful, and an EEG was done, which showed multifocal spikes with intermittent slowing. The genetic testing demonstrated that this little one had a de novo PURA mutation. And I know there's a lot of controversy about levetiracetam. We'll address that, but the child was started on levetiracetam, and there had been good seizure control for at least the 6-month follow-up. The one takeaway with this is that we really are thinking about medications when we talk about conventional anti-seizure medications that have broad spectrum. Now, historically, levetiracetam was frequently used. It's considered one of the more benign medications, but that doesn't mean that it's effective in all of our children. There's valproic acid, lamotrigine, and then maybe some of our newer medications that we don't have a lot of data on, clobazam or perampanel. Again, when we talked about, is there a correlation of genotype and phenotype between severity, there's also no clear correlation between response to anti-seizure medication. But again, we have a smaller cohort and there may be more to learn. For infantile spasms, we're treating them with conventional hormone therapy or vigabatrin. And when seizures are more refractory, the ketogenic diet is an important consideration. And through this, it's really multidisciplinary care. So I want to bring up a concept that's used in other developmental epilepsy populations about the concept of the serial EEG. So what we know is that EEG abnormalities may actually precede seizures in people who have PURA syndrome. Those are, again, nonspecific, slowing or seizures or epileptiform discharges. We also know that serial EEGs may potentially guide intervention. So, in addition to if a child's having a new spell, doing something that's not clear, or an adult, or if you notice regression, those are pretty clear indications to do an EEG. But what if there was a role for maybe preemptive? And so again, I want to be clear, this is not a routine expectation, that this is still a must use your clinical judgment. So the question that I'm posing then is there a role of treatment before seizure onset? And, and I think the biggest things to consider are, what is the risk of epilepsy, or what is the risk of seizures? And maybe the epileptiform burden might be helpful to consider. And so we're using the EEG to guide risk. And levetiracetam has often been recommended because it's a lower adverse events type of medication, but there probably are others. And so we're not stuck on that. And this is, of course, going to need careful discussion and shared decision-making because there is no standard. What about in the circumstance of developmental regression and seizures? And so this is, I think, Many of our developmental epileptic encephalopathies, we have this concern about um, developmental regression. And so we know that seizure onset may coincide with some skill loss. We know that there can be very subtle seizures, behavioral arrest or eye deviation that can be very difficult to characterize. What are they? We know that there's an interest in the PURA groups about, are there even reflex epilepsies related to bathing or water immersion? Like, these are all really important things that we need to be thinking about. And getting an EEG can be helpful, although I know that it's not always definitive. So I'd like to talk about tuberous sclerosis as a proof of concept for serial EEGs, as throwing that out there. We know that 70 to 90% of individuals with tuberous sclerosis have early onset and developmentally refractory, drug refractory epilepsy that we know significantly can impact their neurodevelopmental outcomes. We know that seizures in these children tend to occur in the first year of life, often with this earlier in infancy at the 4 to 6 year old level. And we know that early seizure onset is well defined in the TS population as a major risk factor for subsequent intellectual disability and developmental delay. So here in this population, the EEG abnormalities that are tracked in these serial EEGs are specifically interictal epileptiform discharges. So these are abnormal impulses that often precede clinical onset of actual seizures from weeks to months. And this can then give us this window of early detection and intervention before actual seizure onset. And so in tuberous sclerosis, serial EEG monitoring is a cornerstone. We call them surveillance EEGs. And in asymptomatic children with tuberous sclerosis, it's every 6 weeks for the first year of life, and then every 3 months up until the second year of life. And then, of course, always, as clinically indicated, they did something that you need to characterize. So what is the impact then of surveillance in this population of tuberous sclerosis? And they found that interictal epileptiform discharges on this serial EEGs was a strong predictor of impending epilepsy by age 2. Specifically, the timing and location, like multifocal, was more likely. And therefore, children were started on vigabatrin, which is a very specific medication that's often used because of the mTOR pathway. And I'm not going to get into that today, but they use vigabatrin before the onset of clinical seizures. And this was really strong, high quality evidence in this EpiStop trial, which showed that preventative vigabatrin resulted in delayed time to first seizure, reduced the risk of drug-resistant epilepsy and infantile spasms, improved cognitive outcomes at 2 years, and there was no increase in adverse effects. And the other important question then is, what about long-term? It led to better epilepsy control, higher median IQs in the school-age child at that follow-up compared to conventional treatment, which would be wait until seizures start and then you would treat. And that being said, this is still underutilized globally. And there are many reasons for that. People might be fearful, my child doesn't actually have seizures yet. Do I really want to put them on a medication? So you can think of those challenges. I also want to say that this may be something that's more specific to tuberous sclerosis because the medicine that's used, which is vigabatrin, is actually an mTOR inhibitor, and tuberous sclerosis is part of the mTOR pathways of epileptogenesis. So there may be disease modification, not just any random anti-seizure medication. So next I'm going to shift a little bit to brain metabolism on the ketogenic diet and just kind of put the groundwork that ketones fuel neurons and reduce excitability. We'll talk more about those. They may enhance mitochondrial function, and they shift brain metabolism from using glucose as an obligate substrate for brain energy to ketones, which are beta hydroxybutyrate and acetoacetate. And we're basically using those ketones as alternative energy sources for the neurons, the glia, when glucose transport is impaired. We know that the ketogenic diet also modulates neurotransmitters with increasing GABA and reducing excitation on the glutamatergic pathways. So what about the ketogenic diet in PURA syndrome? I want to be clear that there are no formal studies of the diet in this syndrome. There are case reports, however, and there have been anecdotal reports of seizure reduction in refractory cases. If we use another developmental epileptic encephalopathy as a model, so there is evidence in Angelman syndrome data that there can be seizure reduction in 80% of children, meaningful reduction, which is at least 50%. And we don't know what the impact is on development, because we're talking like, is this just seizure control, which is not it would be wonderful, but also how is this impacting development? And so that's still unproven. But we know that our children can have feeding difficulties, the low tone, there's risks for aspiration. So this has to be very carefully considered. You don't want to be aspirating fat into your lungs. And so the last part of this is, could there possibly be a role for neuroprotection? And I will tell you, for full disclosure, I run our ketogenic diet clinic here at UT Southwestern and Children's in Dallas. I've been doing that for over 20 years. And there's this very interesting concept in the ketogenic diet world about neuroprotection. So it's being used in brain tumors, trials in Alzheimer's, Parkinson's, ALS, because of this concept of neuroprotection. So what about specifically in Angelman syndrome? This was a small cohort. The original small cohort was published by Mass General in 2012, and they showed this reduction, 50% reduction, at least in 80% of children. And the other thing that I think was really interesting was that some parents, even before the seizure reduction was quite evident, reported increased alertness and attention. I do want to say, though, when very formal neuropsychologic testing was done, this was not seen in the formal testing, but many families sort of were struck by this. So now I'm going to jump back. Remember when I told you that we want to think about glucose transporter and that PURA may have some mechanism on glucose transporter? So we're going to come back to this now. So there is a disorder called glucose transporter 1 deficiency, or de Vivo syndrome. This basically, there is a protein, it's a glucose transporter, which is a protein that transports basically sugar from the bloodstream across the blood-brain barrier, where it can then be used in the mitochondria in the brain to perform energy, to give energy. This glucose 1 protein is encoded on the SLC2A gene on chromosome 1. And then this deficiency state, one of the 2 genes is damaged by a mutation, so insufficient protein is made. And so you're not getting enough glucose going into the brain. What happens with this is that it affects brain development and function, because the brain wants to use glucose. It is the primary fuel for the brain. And you're basically, I say you're starving the brain of a substrate of energy. In this syndrome, glucose transporter deficiency, 90% of the cases are de novo mutations, but there are some rare autosomal dominant inherited forms. And the treatment is actually the ketogenic diet, which I gave you that whole thing about the diet earlier, is we're giving the brain an alternative substrate. So we know that there are reports in some individuals with PURA syndrome who have low CSF glucose. So is this some sort of GLUT1-like phenotype? So these have been case reports. The testing of these children showed that they had normal SLC2A1 functioning, so it wasn't absence, there was no gene mutation, but there was reduced expression of glucose 1 transporter. Functional studies showed that the PURA protein directly influences GLUT1-mediated glucose uptake, and this is probably in 2 ways, maybe through regulation of that or some sort of physical interaction with the transporter. And so there's a suggestion that PURA may regulate GLUT1 and glucose transport into the CNS. And there are some clinical expressions that may mimic GLUT1 deficiency, such as Both of them have early onset, drug-resistant epilepsy, low tone, and movement disorders. So the implication, what I'm proposing, is that these metabolic GLUT1-like phenotypes may cause this potential GLUT1 dysfunction, and this might be contributing to the neurologic phenotype. But I want to be very clear, these are just case reports, and the degree to this is variable. So like most of the things we've been talking about today, this is not 100% correlative, but it may offer a therapeutic target. So my suggestion is to consider CSF glucose testing in PURA patients who have refractory epilepsy. And, I was very interested to hear about the biorepository and things that were talked about this morning. And, maybe at some time CSF collection might be part of the biorepository. So what about metabolic testing and interpretation? So CSF glucose and lactate, if you have seizures, you have to still rule out the SLC2A mutation, and then you might consider evaluating GLUT1 dysfunction. And there are both assays and functional testing which could be helpful. So management, there's no formal treatment protocol. So I'm not standing here to say everybody with PURA should be on the ketogenic diet, but I think we should be thinking about this so that tailored treatments might be an option based on symptoms, EEG findings, metabolic biomarkers, and that this would be a case-by-case basis. But there are some things to consider, like maybe we should be really thinking about avoiding prolonged fasting, right? So if you're fasting and it's prolonged, you're going to have a lower glucose state. And maybe that, if you have this sort of dysregulation of transporting glucose using the GLUT1 transporters, perhaps you should avoid a lower glycemic state in the bloodstream. And then close follow-up, glucose homeostasis, especially when children or individuals with PURA are ill. So what are the clinical outcomes? So this is outside of what I just said. This is just in general with individuals with PURA. So, the literature is varied. Some things will say, oh, it's quite manageable with anti-seizure medicines, and others say that it can be quite refractory. And like I told you, it can be anywhere from a little bit easier to control to Lennox-Gastaut syndrome. But there are many medications, but none that have been proven to be specific. I do think in understanding excitatory pathways, I think that perampanel may be another option to consider. But again, there's no clear data. With infantile spasms, we're using the typical treatments and, have those conversations about diet. We know that developmental delays typically persist, but the seizure burden itself can be variable. So it doesn't necessarily mean that it will be the same level of refractoriness or less refractory across the lifespan. We talked about how we don't really have a great ability to know prognosis based on mutation, but I put a question mark by that because who knows what the future brings when we have more data. But definitely seizure burden and other comorbidities might be impactful. And this is where long-term monitoring and personalized treatment plans are very important. I also want to say that there's an important role of the multidisciplinary clinic. These are complicated. It's complicated to set up. It's complicated to run, the day. They can be long and hard for families and individuals coming to the clinic. But I think that there is this benefit of having this cohorted care, which includes genetic counseling, seeing your neurologist, the metabolic team, having nutrition, feeding therapy, OT, PT, speech. And then, of course, the big concern that we all have is where do we transition our children to when they get older, especially understanding that adult neurologists, this was not really what they signed up for, right? They didn't become adult neurologists to be dealing with developmental epileptic encephalopathies. But I will tell you that is changing and that there are some individuals who are really interested in partnering with us. I think, when we hear from families, this is one of the really powerful things about being here and attending this, and I'm so grateful to have been invited. is we know that natural history studies are really valuable. We have to understand what development is, what seizure outcomes are, so we can understand progression and response to therapies. I think I went back a slide. Hold on. Future. Okay. Did I get to family perspectives? Yeah. Okay. Sorry. Let me go back. Oh, now I'm stuck. Okay. Just close your eyes for 10 seconds. There we go. All right. Now you're seeing it for the first time. So what we hear from families is that it's an odyssey, you know, and I don't use that word lightly. It is a difficult journey of getting the right diagnosis, getting all the people that you need on your team. It can be delayed. It can be frustrating to talk to neonatologists about, you know, need for, do we delay doing a trach or not? Like what is going on? And I think that families are carrying a large burden. We know that what we hear is that education, connections, resources, and advocacy are vital, and that's what these types of conferences do. And that knowing that we have organizations like the PURA Syndrome Foundation and hearing about the international groups, I think, and how there's such strong collaboration, and even with other rare disease communities. So in my last few minutes, what are some of our future directions? So natural history studies, as I was saying, we need to understand what the entire phenotype of the disorder is so that we can target and learn and make those best mouse models, figure out who's going to have the easier to control versus the less control, what medicine seems to be more helpful versus another. We know that there may be a role of EEG as an early biomarker. This is just a concept I'd like to throw out, and that there is data from other models of developmental epileptic encephalopathies and tuberous sclerosis and Angelman's that might be models for us. We know that currently the work is on really targeted metabolic therapies, gene editing, RNA-based strategies, and so it feels like there's a lot of hope and promise. Final takeaways, it's that this is an evolving diagnosis. It's very diverse presentations. Although seizures are very common, there's a wide range of responsiveness. Consider the monitoring, continue to do the research, and collaborate and work together. And I have some selected references, and thank you. And I think Q&A is at the end, right?
Yes.
Okay.
We're gonna. Okay.